All right, Chapter 8, the Professional Rescuer CPR. Now, when we talk about cardiopulmonary resuscitation, we're going to stay pretty close to the American Heart Association way of doing things, okay? Now, because of that, they operate, and we all should operate, in the CAB method, meaning, do I have a pulse? And without that, I need to have an open airway with some breathing. Now, airway and breathing skills are very good to have for a patient whose heart is still beating. And so if my heart is still beating, then I'll do ABCs. But when it's not, I need to work with CABs, right? I need to start somewhere. Now, our goal for CPR is to maintain or to restore circulation manually by performing what we like to call chest compressions. And then together with breathing, we're having a good chance of keeping the body viable to shock and to give medicines and to bring back, right? Now, 70% of the patients in cardiac arrest are in what is called a state of ventricular fibrillation. It's basically when the heart is quivering. Something has gone on in too many of the individual cells, which have automaticity, like we talked about in the anatomy uh, chapter. They're all firing and causing a mismatch there, and it's no good heartbeat out of that. That's fibrillation. That's fibrillating. All right, let's talk about what normal is. Let's talk about what a cardiovascular system is supposed to be about, right? We talked again about normal from the anatomy chapter. It takes a heart, which is the pump, a network of pipes, otherwise known as the blood vessels, and the fluid, which is the blood. Now, specific to cardiac arrest, we're dealing primarily with a failure of the pump, right? The heart. And the heart is located in the chest between the lungs, and it is substernal, slightly to the patient's left. The heart, as we talked about before, consists of four chambers, two on the right side, two on the left, separated by what is called a septum, and separated top to bottom, atria on the top, ventricles on the bottom. So you have a left and right ventricle, and you have a left and right atria. The upper atria are the uppers, ventricles are the lowers. The order of operation is when the heart beats, the atria contract and push the blood through their valves into their respective ventricles. And the ventricles then press it out into the body. As it's being pressed out of the body, the atria are refilling. They're one-way valves flowing in only one direction. As you see here, there's a diagram about the flow of the blood through the body, right? Now, what I really appreciate about this diagram is that, sorry, it gives you the exact valvages as where they come in from. So from the body, it's dumping into the right atrium. And it goes through a valve into the right ventricle, then out to the lungs. Right? So from the right ventricle, I'm going out to the lungs. I return from the lungs to the left atrium, and then from the left atrium, I go down through a valve into the left ventricle, which is the most powerful of the chambers, the most meaty, and then out to the body. Okay? You don't need to really know those valves, but it's nice to know, or it's nice to know if you want to. And all you really need to have are the chambers. Now, as a reminder, and we talked about this again in the anatomy chapter, arteries carry blood away from the heart at a high pressure. And it's designed that way to get you all the way to the arteries, the smaller arteries that then connect to the capillaries, which are right at the cell level, the muscle level, so that we can feed those systems. Now, as it clears the capillary network or into the veins as it returns the blood up to the heart to be pumped to the lungs and start all over again. Veins are thin-walled, they're low pressure, and veins have valves. Now, we're also having, anytime you have an artery pass over a bone, we can feel a pulse, okay? The most common, the major points that we'll feel are the neck, which is the carotid, the wrist, which is radial, the arm, which is right there above the elbow a little bit, that's the brachial, and then you have in the groin femoral. The pulse that I'll use on a conscious patient is the radial, and the pulse I'll use on the unconscious, unresponsive, probably the cardiac arrest, is going to be the neck. And so we see here the different locations. A is the carotid, B is the radial, C is the brachial, and D is the femoral. Blood has several components. Again, a reminder, it is made up of plasma, which is the water part, the red blood cells, which are your trucks that carry the oxygen and the nutrients to your cells, and then picks up the garbage, takes that to the different waste systems. The white blood cells are your soldier cells that go out and devour the bad things, trying to beat them up or eat them up. And then the platelets, they're out there trying to start the clotting process for your blood if there's a hole there. Plasma makes up about 55% of the total blood capacity, and then everything else, all of the different types of cells, are 45%. So you can see if they are dehydrated, how that might affect blood pressure and pulses and things like that. So let's get into the specifics of cardiac arrest. Cardiac arrest happens when the heart stops contracting. No blood is being pumped. And without a supply of blood being pumped out, especially to the brain and the heart itself and the lungs, we begin to have cell death. Brain damage begins about 4 to 6 minutes. And then after about 10 minutes, we become severe, maybe even reversible damage to other tissues. Okay, and so we want to make sure that we begin good, high-quality CPR as quickly as humanly possible. Some different causes of cardiac arrest. Well, maybe there's some sort of a disease that's going on that caused it. Maybe a respiratory arrest left untreated causes it. Multiple different kinds of emergencies, medical emergencies. A drug overdose, that would actually, there are some where that would cause a direct correlation. Cocaine overdose does tend to hurt the heart. Or it might be a narcotic which knocked out the respiratory drive, leading to a cardiac arrest. Drownings and suffocations. And then, of course, if I lose a lot of blood, there's nothing left to pump, then the heart will just stop pumping altogether as well. Now, patients who are experiencing cardiac arrest, they're going to look like they're having a bad day because they are, in fact, having a bad day. You cannot feel a pulse, and the patient looks dead. You go up, buddy, are you okay? No response. And regardless of why they went into cardiac arrest, your initial treatment is going to be, I begin CPR. I start cardiopulmonary resuscitation. Now, what does that mean? All right, we know what normal is. We reviewed that. Now we're going to talk about what we're going to do to fix this. All right, 3 different skill types, and we've talked about each in turn, but now we're going to talk about circulation. All right, we're going to start with our circulation, then we're going to worry about airway, and then we're going to worry about breathing. Now, airway and breathing skills we've already touched on in previous chapters. We have to determine whether they're open, we have to correct any blocked airway, and we need to use either the head tilt chin lift in the non-trauma or the modified jaw thrust in the trauma. If the patient is breathing, we need to determine whether it's good type of breathing or whether we have to perform rescue breathing, right? So agonal respirations are respirations that are incompatible with life. Anywhere from 1 to 6 a minute. They're going to be slurpy and they're not going to be very good depth-wise. Those are agonal respirations, and we need to override back for these people up to 12 to 20 a minute. So first off, I'm going to open the airway and I'm going to look, listen, and feel, right? Do I see, hear, feel anything? Nothing. I check for pulse, no pulse. I begin my compressions. Now CPR is a reminder in and of itself is not going to sustain life indefinitely. We need to start it as soon as humanly possible, but I need to defibrillate the heart. Remember, 70% of the cardiac arrests are called from ventricular fibrillation. So I need a defibrillator, a stop your fibrillation heart thing, to zap them back into a workable rhythm. And coupled with medicine, we can be very successful with medicine. Well, I don't have medicine. In fact, the EMTs don't even have medicine. We as EMRs don't have medicine. EMTs don't have medicine. However, the medics do. And so we're going to call for advanced life support to be useful here. So as we begin to think about what's our steps, what's our procedure in the cardiac chain of survival, in the American Heart Association chain, first off, somebody somewhere along the lines has to recognize that there's a cardiac arrest and we need to call 911, right? And that begins. Then CPR begins with high emphasis, with an emphasis on high quality CPR compressions. I want to make sure that I'm pressing on the chest in the proper way, pressing down 2 inches in the center of the chest, the lower half of the breastbone, but not on the xiphoid. I'm going to press down at a rate of 100 to 120, allowing full chest recoil, and I'm going to do that for 30 compressions before I try to breathe twice, right? We've talked about this in our CPR classes before, right? And all of those things are going to what we need for high quality compressions, right? Then I want to get that AED on there as fast as humanly possible. Basic and advanced EMS to show up, and then we need to maintain at the hospital. That's part of the chain of survival. That hospital links there. So again, if it helps you to see it, well, then this is the best way to do it. This is your visual. Recognize the activation. Recognize and activate EMS. If you are EMS, you just begin. Immediate high-quality CPR. It's hands only for the civilians, and we'll add respirations for us. Rapid defibrillation. So as soon as the AED gets there, I'm going to use it. I need to get them transported as soon as humanly possible. And try to get ALS involved as well. Because while the BLS truck will show up, ALS is where we need the drugs and so forth. Then as you get to the hospital, okay, then they can take over and do some things, and hopefully they get recovered and sent home. Well, when do I start CPR? Now, we've talked in our previous classes, and you've had previous classes, CPR, about how to do CPR, right? So this is a review of that. But when don't we? Or when do we start and when don't we start? CPR should be started on all CPR should be started on all non-breathing, pulseless patients, apneic and pulseless patients, unless they're obviously dead or have a valid DNR, like right there, stapled to them or something like that. But obviously dead would be they don't have a head. Okay, the head is separated from the body. I don't need to start CPR. There's no hope. If they have rigor mortis or liver mortis, rigor mortis is the stiffening of the muscles. It occurs after death, and then it releases, and then it sets in finally. Also, it has lividity, liver mortis, where the blood pools to the lowest point, so it looks like it's bruised. We see those things. We don't start because there's just no reason to. They're never coming back. If they're decomposing, right, we don't need to start. And I already told you about the dependent lividity, the pooling of the things closest to the ground. We only stop CPR in a few instances. Number one, first and foremost, If the patient swats your hand away, you can go ahead and stop because you have actually done what you need to do. You've returned spontaneous circulation and restored the patient's vital signs. Spectacular. They come back, we call that ROSC, return of spontaneous cardiac. If we get ROSC, we win, right? Another reason why you personally can stop is EMR. I transfer to another trained person with equal or higher level than training to me. So I could transfer to another EMR or an EMT or a paramedic, but I couldn't transfer care to somebody with just a CPR card. Now, somebody with a CPR card could help me, like a firefighter, but if they are not EMR qualified, I can't just get up and I got to go to work. No, then you'd be in abandonment. A physician orders you to stop. That's another reason. You say, okay, that's it. Time of death, we're done. Okay? Those are the only real reasons to get stopped, right? So the last one is, I'm just too tired to continue on. You don't have the resources to continue on. You're exhausted. You can't physically press down farther. And of course, if you look up and realize that, wow, there wasn't a head, or there was only a partial head, or maybe I have a head but there's no brains left, maybe you could, just call that a day as well. If you're ever in doubt about when to stop, call med control. Okay. So what do we do for external compressions? Now, if you look at your skill drills, it'll give you the specifics on how to do this. But again, we start with my BSIs are on, my scene is safe, buddy, are you okay? No response. Call the code, get the AED, right? And then I begin compressions. Now, when I'm looking over the patient, I'm checking for a carotid pulse. I'm checking to see if they're moving. If the patient is moving, even if I can't feel a pulse, then they have a pulse. The only exception to that is that agonal respiration, right? Now, when we talk about an infant, though, and we're doing compressions on an infant, we have to make sure that they are truly in a rest. We check for their pulse at the brachial. Now, we see this young person is actually just being a good guinea pig right there, probably mom or dad or whoever's doing that. And we're just, checking the brachial. That's where we check on the infant. Everybody else goes to the carotid. If Junior is not, in fact, alive, we begin chest compressions. Now, this is a method that we could use. I prefer putting an infant on a table or a cot or something that I have good access to, and having other people to assist me rather than keeping it in my arm. If I'm by myself, then maybe I do it this way, right? Solid surface. You're not going to need to use much force because they're very pliable. As I'm doing compressions, we need to make sure that we check our pulse points, because if I feel a pulse with compressions, that means I'm doing good compressions. For a child, so for an infant, I'll use 2 fingers, like we saw here, 2 fingers in the center of the chest. For a child, I'll probably use 1 hand. And if they're a bigger kid, on the order of 12 and 13, and just right there, I'll probably use 2 hands depending on how big the kid is. Remember, our ratio for 1 rescuer is 30-2 for the adult. It's also 30-2 for the 2 rescuer for the adult. All right? So, again, look at your skill drills, and it'll walk you through that point of that. If you have more people, the better you will be, because you'll stay fresher. You should switch positions, airway to compressions, every cycle. The cycle is 5 sets of 30-2, right? You only have about 10 seconds, though, to switch out. We're not going to spend a lot of time, reassessing and doing other things. We have 10 seconds to be off the chest. So I do my 30 compressions. The person at the head does their breaths and immediately goes to compressions. That's how we play that. So we have good, smooth transition. If we have more people, even better. Now, if I'm alone with with an infant, I'm still going to do 30-2. Again, with my fingertips pressing down, this is about 1/3 to 1/2 the chest depth at about 100 to 120 compressions per minute. Anywhere from, let's see, what's a rate of 100 beats? You could do Staying Alive, ah, 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 staying alive, staying alive. Or you could do da 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 da. Another one, Bots of Dust. Well, those are good 100 beaters. If you want to go up to 120, it would be Baby Shark doo 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 doo, Baby Shark doo 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 doo, Baby Shark. Don't sing these things out loud because that's just awkward. But if you need to have a tempo, that's how you do that. 30 compressions, 2 breaths. You do 30 to 2 for 5 cycles. Then you switch out if there's somebody else there. Now, for 2 rescuer though, we switch. We do 15 compressions to do ventilations. And now I'm doing 2 thumbs on the chest rather than 2 fingers. And that way the baby, the infant, is now, the airway is facing my backup person, my second person, and I am doing compressions, or vice versa. Child is essentially the same as the adult. The only change there is for 2 rescuers, you'll do 15 to 2 for the child. Everything else, relatively speaking, is the same as the adult. Now, how do I know I'm doing effective CPR? Well, the person at the head, the person that's doing the airway, should put their fingers on the carotid for the child and the adult, and you should feel a pressure wave as that's going on. You can feel on the infant at the brachial, but again, it's going to be a little bit harder because that's a smaller critter. If the patient's skin color improves from a blue to a pink color, that means that we're doing good and effective CPR. I'd like to see the chest rise visibly during the ventilations. And doing all of those things at the appropriate depth and rate. We don't want to go too fast. We don't want to go too slow. We want to go just right. Now, some of the things that we might run into as something that is a problem, or not really a problem, but a complication of CPR. There's many people that say, if you do CPR right, you won't break a rib. I have not, in 30 plus years, ever done CPR without cracking a rib or dislocating a rib on the patient. And obviously, the more mature they are, the more brittle they are, the more easily they will break. So ribs, typically speaking, will be cracked and or broken. Now, we can reduce that if we have our hands in the proper position. But you will probably always hear some sort of a cracking or crunching as you're doing compressions. It is very, very normal occurrence. Something else that is very normal is when you get too forceful with that air going in, and when you start breathing out of turn with the compressions, you might see some gastric distension because we're blowing air in too fast and too hard, and we're doing it while there's compressions going on, and therefore I get some gastric distension. That means you're going to throw up or regurgitate because they don't throw up while they're unconscious, and then we're going to do some suctioning. So we don't want to bag too fast, and we don't want to bag too hard. But what we can do is if we have that eye gel inserted, which we all will know how to do, then once the eye gel is inserted, then I don't have to worry so much about that gastric distension. If the patient regurgitates, if they throw up, and I don't have a suction available, I need to turn them on their side, scoop it out, and then get back to work. It's very common for that to happen, but we need to make sure that we have suction standing by to clear this area. If we don't clear the airway during CPR and we're bagging, we could blow vomit right down into the lungs, which is going to really cause some additional issues, assuming that we get them back, right? And we don't want to do that. We don't want to make it worse, right? One of our things is we don't make things worse, right? Now, if in fact you find that you are alone on this arrest, you show up first, you've got to get yourself ready for the next incoming team. We don't just, go to it wherever we are, because that may not be the best play. We need about 3 to 4 feet all around the patient to do effective CPR, right? Because we need to be able to get in there. And we don't want to step over the patient if we can help it. We don't be tripping over their stuff. We don't want to step on them, right? So we might have to pull them out of the bathroom, which is the common place for them to go down. And normally they go down with their pants around their ankles because they've been pushing so hard to poop. So you might have a little brown smear that's coming with you, but that's what you got to do. We don't take a ton of time though. I kick stuff out of the way, I yank them, I get started. Now, we talked before about defibrillation. Good effective CPR will maintain the body so that we can shock them, we can defibrillate them back. Again, 70% of all out-of-hospital cardiac arrests are caused by a fibrillation. Well, if I have my AED on there, it will recognize that and then shock it. It's a vibration of the heart that is incompatible with life. It says to all the extra people that are trying to be in charge in the heart, stop it, let the main person be in charge again. The best way to reset that from VFib to back to a normal sinus rhythm is to hit them with the AED. Multiple different kinds. The first and most important step is you turn on the AED and let it tell you what to do next, especially if you have a different kind of version than what we practice with here in class, or even if you have it at your stations. The first step is always turn on the AED and then listen to its instructions, following it to the letter. Now, it's your job as an EMR not only to maintain your your EMR license and certifications, but you will also need to have a valid CPR card. Remember, CPR cards expire every 2 years. So there's that. So for every license period, you probably will have 2 CPR cards. And that's fine. Things that we need to know while we're doing CPR: if they have advanced directives of living wills or whatever, we've got to be careful about saving people that don't want to be saved. But if they don't have the paperwork right there beside them, how am I supposed to know? And I'm not going to withhold care just because someone said that there was paper somewhere. We need to start CPR on all patients unless there's obvious signs of death and or that directive or DNR is right next to them where we can see, okay? Do not hesitate at all. If you don't find a pulse in 10 seconds, there is no pulse. If you don't find breathing within inside the 10 seconds, they are not breathing. And you have to know that if you don't do something, if you don't make a decision to help them, your patient will die, okay? Now, if I start pressing on the chest and they smack my hand away, well, I don't need to press on their chest. If I blow in their mouth and they smack my face away, well, then I don't need to blow in their mouth. But it is considered abandonment if you discontinue CPR after you start without the order of a licensed physician, or you have turned it over to a higher level care provider, like an EMT or a paramedic. Okay? You cannot just stop because I don't want to do it anymore, unless it meets those criteria we talked about before. Okay, that is the entirety of Chapter 8. Here is your couple slides of summary. Cardiac arrest occurs when the heart stops, right? If you are arrested, you stop, and no blood is being pumped through the vessels. Your chain of survival that you might hear a question about on is recognition of the issue and activation of EMS, immediate high-quality CPR, rapid defibrillation, basic and advanced EMS, your ambulances, and then ALS, which is your hospital and post-arrest care. We support our adults and children basically the same way. Buddy, are you okay? No response? Check the pulse. No pulse, no respirations, beginning CPR, right? Circulation, breathing, airways, the way we do that. And anytime that there's an airway obstruction, we need to be aggressive at clearing the airway, because without that, remember that every patient dies 100% of the time without an airway. The single most important cardiac arrest survival factor is, you guessed it, early defibrillation. But I can't shock them if I don't have a viable human creature. That's where CPR comes in. And the AED is used anytime the patient is unresponsive, not breathing, and has no pulse. Okay? You never put an AED on somebody that has a pulse. And then finally, once you have turned it on, the AED, and attached it to the patient's bare chest, let the AED do its thing, and it'll tell you. And follow its instructions, and make sure that if it's a fully automatic, that you don't get shocked during that time frame. Okay? Chapter 8.